Hello, everyone, and welcome to the latest episode in the TechSite webinar series, Pioneers in Digital Pathology. I'm your host, Jacob Hicks, and I'm delighted to have Dr. Evann Hilt join me today as she'll share what it was like for her institution, the Academic Medical Center she'll introduce more fully, where they implemented the TechSite Parasitology suite and went digital and applied assistive AI. Dr. Hilt, I'm excited to learn a lot more from you today. We will have time as usual for Q&A at the end, so drop in your comments, your questions, our listeners. And as a reminder, this content will be available on demand later as well. So a bit about Dr. Evann Hilt. She has a PhD and is the medical director of the Infectious Disease Diagnostic Laboratory at the University of Minnesota and an assistant professor of laboratory medicine and pathology. Dr. Hilt's expertise includes diagnostic microbiology, digital pathology, molecular diagnostics, and implementation of novel laboratory technologies. Case in point here, what we'll learn more about the specific implementation. So I'll briefly share on today's agenda a little bit about TechSite for our new listeners to help you understand what the TechSite Fusion platform offers. And then we'll turn the time to Dr. Hilt for the majority of the session. And you can see some of the milestones she'll share, why they made the change, what it was like transitioning to digital, how they validated, what those results look like, feedback from the lab staff and the wider team, and lessons learned. Again, drop your comments, questions in the chat. So briefly, a bit about TechSite. TechSite is one of the leading digital pathology platforms in the world and the only one that offers workflow AI and diagnostic AI solutions across anatomic and clinical pathology. TechSite has solutions in histology, cytology, microbiology, hematology. So as your institutions consider transitioning to digital and or even applying some diagnostic AI, the TechSite platform at over 10,000 locations can help you, and it's among the most scaled platforms in the world, having done greater than 11 million diagnoses or assistive diagnoses in clinical production. This is not research, this is not proof of concept, but actual production use with real patients. We were originally a technology transfer company out of the University of Utah and ARUP laboratories, and have since grown and expanded our breadth. When I mentioned the cross-pollination of different departments that the TechSite Fusion platform can serve, you can see examples of the medical disciplines as well as the workflow and AI tests that we offer and ones that are coming. On the right-hand side, we just like to point out that TechSite is a lot more than just a viewer or an image management system. Of course, we need to enable that as institutions go digital from microscopy. But beyond that, we really have tried to focus on fitting into a laboratory's workflow to drive efficiency and accuracy gains. You laboratorians are experts. You know what it's like to translate a foreign specimen from someone's body and make sense of the information the body was giving, whether it was stool or urine or tissue or bacteria. You are the experts. And so enabling your workflow to get results out faster, more accurately, and enable your team to do its best and brightest work by having tools that support that. The TechSite platform has been designed that way, from LIS integrations and EHR integrations to scalable SOC 2 HIPAA compliance, recognizing the criticality of IT security, and applying AI, and even helping you with optimized good images that help you make a clinical decision. That, of course, is essential if you're going to transition from microscopy to digital. A bit about regulatory. The TechSite platform in the United States is for research use only. In the EU, we are CE marked with many of our solutions, and in the UK, we have UKCA certification. So without further ado, I'll step off stage and turn the time to our wonderful expert today on the webinar series, Dr. Evann Hilt. Thanks again.
All right, thank you, Jacob. And I want to thank the organizers for inviting me to give this webinar today to kind of debrief and give an overview of our experience implementing digital parasitology into our laboratory. Before I get started, though, just want some disclosures. I have received funding with Roche. The views here are my own and do not necessarily reflect those of my employer or affiliated institutions. This discussion is for educational purposes only, and any mention of instruments or different technologies are descriptive for our implementation experience and should not be interpreted as endorsement or recommendation. Again, just kind of a little bit more detail of the objectives for today. The key considerations to take into account when implementing digital parasitology: understanding workflow integration for the whole complete ova and parasite exam, recognizing the different validation and operational challenges that you may face, and then kind of discuss our lessons learned during this implementation. But before I get into our actual experience, just want to, again, Jacob gave a really great overview of TechSite as a whole, but I just want to kind of focus fully on digital parasitology. And, you know, this is the application of using microscopic examination for parasitic organisms, and this combines both whole slide imaging of our parasite preps, digital image management, AI-assisted identification for potential parasitic organisms, and then, of course, our technologists and their experts on actually verifying and interpreting what AI has potentially identified. So unlike our traditional microscopic workflow, this creates reproducible digital images that can support the diagnosis, any consultation, education, and quality assurance, while also maintaining our technologists being the experts in reviewing it. So why we considered moving to digital parasitology? There were several factors here. First and foremost, those of you who know the ova and parasite exam and prepping these slides and reading them, it can be a labor-intensive workflow. Hundreds of microfield slides are required to review, and in our case, and what is generally seen, is that predominantly these are negative specimens. So you're doing all of this work, you're doing this intense examination, looking through all these slides when they're all negative. This is also can be very subjective, so intra-observer variability, and this is all dependent on the technologist's experience, and that takes time to build. So training in this area can be very time-consuming itself. But then again, too, going back to the actual workflow of like actually screening these, it takes a long time. And even from like an ergonomic perspective, having to sit at a microscope and go through 20 ova and parasite exams in a day can be a lot on our technologists. And then the other thing that we're facing as well is that we do have an aging workforce and training challenges. So, you know, the world of lab today is people aren't necessarily sticking to one lab and staying there for their entire career. People around, and again, all of our truly trained and expertise within parasitology is leaving, and so that knowledge transfer itself can be difficult. Again, it takes time and effort and just seeing these things over and over again to really gain that expertise to feel confident in calling things out. So our goal overall was to improve our workflow efficiency while trying to preserve that technologist expertise itself. So again, like that labor intensive, like hunching over at a microscope for hours in a day, like can we try to improve that and still maintain the expertise that we have? So why we were well positioned to implement this, there's kind of several different factors here. I think one of the biggest things is we are an academic medical center. Our infectious disease diagnostic laboratory is a high complexity laboratory, and we are centralized for our entire system. We serve 10 hospitals as well as a variety of over 200 outpatient and outreach clients combined. And the idea too, with being at an academic medical center, we want to support our clinical care while also having education and of course that big driver of innovation. So something like digital parasitology and AI, kind of a big driver there. We do the comprehensive ova and parasite exam, so both direct mount and permanent trichrome workflows. And again, just it required digital. We are requiring, and as we'll go into, we digitize this entire workflow, just not a simple piece of it. Plus, I gotta give it to my team, my lab staff. We have specialized parasitologists as well as the entire lab in and of itself are very motivated and always wanting to take on a new challenge and anything to help improve their workflow and their day-to-day. They wanted to take on the challenge. So again, too, trying to emphasize training, competency, and quality throughout this process. So let's just kind of review again, like how we actually looked at building our digital workflow by looking and seeing what our traditional workflow looked like. And so for many of our microbiologists that may be viewing this, this could be familiar to you. But those of you who aren't familiar with open parasite exams, this is how our traditional microscopy workflow works. So we have our stool specimen. We make a wet mount preparation where we have iodine only and add a cover slip. And then separately at the same time, we're making a trichrome stain, which is a permanent stain smear. And so, you know, the same specimen worked up with 2 different preps. Then both of those slides are examined together to look and examine for potential parasitic organisms as well as host cells using a light microscope. The technologist will try to find and interpret this. It's most of the time negative, and then we'll report that out into our laboratory system. So how we kind of brought in the digital parasitology workflow is as seen here. So we maintained our wet mount preparation being a manual preparation because, again, these samples kind of need to be, again, real fresh and be done right away. But one thing that we did add to the sense of to this protocol was glycerol. So it maintained the cover slip position for when the scanning was taking place and also prevented drying during that scanning process. We ended up automating our trichrome process with an automated stainer, again, trying to kind of help with that manual workflow piece and taking that away from the techs and making it an automated process to also then get away that intra person variability within making the slide preps and just trying to make it as uniform as possible. We then do a whole side scanner with the Promana scanner. This scans both the wet mount and the trichrome stain. And then this is uploaded into the TechSite software, where with the wet mount slide, the whole slide of images are taken, but with the trichrome, it's a defined portion of about 1/8 of the slide. The scans are reviewed. Then once it's in the TechSite system, it uses its magic, as the AI magic, as you can say, to then identify potential parasitic organisms that may or may not be present within those slides. Then what we do is we have our technologists review those slides and kind of review what the AI assisted program has called as like, oh, maybe this is a egg, or maybe this is a type of parasite here. This is what it looks like. And then again, going off of their expertise, they either agree with that call or they don't agree with that call. So if it is a full negative, what they will do is they will call it negative and they will just report it out into the chart. If it is a positive, or if there's some questionable material on that, we will then take the actual slide that was scanned and still do the manual review process to confirm that what the AI program is calling is actually a positive. So again, still using their expertise in that manual review to just confirm. So what I will kind of reinforce throughout this whole thing is that the AI is not replacing our expertise. It is a tool that we are using to help us be more efficient and have a better workflow. And so the challenge here is not necessarily like actually digitalizing the slide itself, but integrating these 2 different preparations and using this technology to help complete the ova and parasite workflow itself. So now moving into how are we going to validate this, right? So I think what I want to call out here is that one of the first questions we had to answer is like, what level of validation or verification is appropriate? We weren't necessarily introducing a new open parasite exam. We're still looking at it the same way and still having the components of it that are the same. So the clinical tests and our reporting practices were unchanged. But we did view this digital imaging and AI-assisted classification as a tool that we're just incorporating into our existing workflow. So, but at the same time, this isn't simply bringing in and replacing a new microscope. AI itself is a new technology for laboratories overall. and it was influencing which image and potential organisms are being presented to us and to the technologists. So we felt just like a simple routine verification didn't fully address the risk associated with that change. So we therefore took an approach that was kind of in the middle, as you could say, where we were performing core performance studies that we needed, but we did a little bit more extensive analytical studies here. So again, what I have listed below are what you would consider for a simple verification, or just your accuracy as well as your precision studies. But what we ended up doing was kind of a little bit more in-depth additional analytical sensitivity with a limit of detection for various organisms. Also some specificity, looking at different cross-reactivity or interfering substances. Also our QC, and we have a client of ours that does pooled stool specimen that we work out from them. So again, kind of doing those studies to make sure that we were doing our best practices for that client specifically. So I'm now going to go into our validation results. So here is a table in the summary of our method performance specification. What you have on the side there are all of the different measures that we have. So concordance, your different precisions, our analytical sensitivity and specificity studies. Kind of in the third column there, you see our accepted criteria of what we would consider appropriate for actually implementing this, and then our actual results. So what I want to also stress too here, it's not the AI alone, it's the final specimen level result that was produced between the interaction of the technology and the technologists. And again, we were looking at the complete ova and parasite exam as a whole, so both wet mount and trichrome. And, you know, not all organisms are seen in wet mount and not all organisms are seen in trichrome. So that's why you need the two together. And we felt that like verifying and validating those separately was not appropriate. So that's why, again, we did the whole entire workflow and how it worked from start to finish. But as you can see, we were well within our acceptance criteria for all of the different measures. And we were very happy with implementing this within our laboratory. So again, I just kind of want to go back to the actual like workflow comparison and like what truly changed for us. So what I have here on the left-hand side of the screen is our traditional workflow, kind of into 4 steps of prepare, screen, identify, and interpret. And those are kind of the measures that were maintained there. And then on the right-hand side is like, and highlighted in red is what actually changed with our digital ONP workflow. So again, kind of like preparing the specimen and making the wet mount itself, we did change adding an additional component to that of the glycerol to help maintain the integrity of the slide as it was going through the scanning process. We automated our trichrome staining. So again, that took it off of our manual workflow. Again, we digitized and screened the actual initial look at all of these slides with the scanning and AI-assisted technology, and then we review, confirm, and interpret. So that in and of itself maintains the same. So kind of some key takeaways with this is, at the end of the day, the patient receives the same diagnostic result, and there's no change in the final interpretation or reporting. And automation was introduced selectively, again, kind of in the parts of the workflow that we felt like we could confidently put that automation. So again, that's the trichrome staining, the scanning, and the AI-assisted screening. And what this has really helped us overall do is to reduce the time spent screening predominantly negative fields. So instead of sitting at a microscope hunched over and looking through, our technologists are looking at the slide and the interpretations on a screen and kind of making that call that, oh yes, this is truly a negative slide. But really kind of the big key takeaway that I want to stress is that this is not replacing our techs at all. Like, we still need their expertise, and it's essential for verifying and interpreting what the AI-assisted screen is telling us. So just their expertise is maintained, and that is what I want to kind of stress here with implementing this technology. So as Jacob mentioned, I think a big key of this, and what I stress too, is how are our techs actually liking this technology? Is this truly helping them? Do they feel like this is a positive change? I mean, I think overall our staff was very excited for this and really wanted to move forward, but we did want to kind of have a measure of, hey, what is your experience with this, and do we actually like it? So we did the following questions there. We asked our employees pre-implementation and then post-implementation. And so what I have here on the right-hand side of the screen is our Likert scale responses. And what you can see is in red are pre-implementation, the average scores for all of these parameters, and then post-implementation. You can see overall, most of them, we saw an increase in their satisfaction with their job performance and what they were doing. And I mean, I think the biggest increases here that I want to highlight is the mental and physical workload, as well as the time pressure. That all of that improved pretty significantly, over 2 points across all of our employees. So I think that is kind of one of those big key drivers that, like, hey, we actually did something that truly did help our employees. And that's what I really love about this, implementing this workflow. So kind of lessons learned, what would we tell other laboratories out there? I think the biggest thing that we have is, and I want to stress, is like, start with your workflow, not necessarily the technology. So really, truly, like, map out your entire O&P process and try to figure out like where digitalizing and using this AI screening tool can affect your specimen prep, scanning, review, confirmation, and reporting. It's not just the microscopy piece, it's the entire workflow in and of itself. Again, as we kind of pointed out, even with the wet mount prep, right? We had to change what we were doing so that we could get good images of the wet mount for the scanning process. So again, it's not just the microscopy piece. And truly, I kind of believe this with any technology that you're bringing on or any type of test, is you engage your technologists early. They are the people performing the work, and they're essential for identifying practical problems, redefining the workflow, and driving adoption of this technology. Because yes, I was a tech back in the day, but it's been forever since I've had to actually make an O&P slide. So for me, it's like, when we were implementing this at first, it's like, yeah, it's just the microscopy. But without the engagement of my staff, they're the ones that are reminding me, like, oh, hey, no, this is important and that's important. So really, truly engage the technologists, because they're the people doing the work, and they're going to know the most about it and help drive adoption of it for the rest of your staff. And then again, to validate the clinical process, not just the AI piece. Kind of, again, rather than treating the item separately, you know, here's the wet mount part, here's the trichrome, or here's the AI classification, it's better to do it as a whole in the entirety of it. So that's what I would put as like lessons learned. So now just a few of the future directions that we have here. On the right-hand side, we have some nice images that we have from our actual screening tool here. But future workflow integration, just kind of getting our LIS and interface a little bit more fine-tuned with this, and maybe move it from digital review to the final reporting, just have it be a little bit more streamlined there. We want to continue optimization, so we are monitoring our performance and QC over time, and we do want to continue to incorporate technologist feedback, especially if there are snafus or things that are just not working. But I think the biggest thing too, especially for us at the academic medical center, but I think even just all true, like just for training new technologists, is that we can use these digital images to help train our staff for education and competency. We can create digital case libraries. So again, we're just expanding the breadth of tools that we have to really train the next generation of technologists, and even like our clinical providers as well. So just working through with that. And then before I end, I really, really do want to highlight and thank my entire IDDL staff, but specifically these three individuals, Shannon, John, and Sue, because without them, this would have never happened. And they were the ones that really kind of took on this challenge and really worked through and are still working through the kinks that we may have today. So really want to thank them all for that. And so with that, I'm happy to take any questions that may have come up.
Dr. Hilt, that's good stuff. I learned some things here about your implementation, and I've also seen those names quite a bit. Shannon, John, and Sue making it happen there on the front lines. That's great.
Mm-hmm.
We have had several questions come in, so I'm just going to dive in.
Yeah.
Okay, Dr. Hilt, Paul asked, I'm interested to know how long it took from the start of the project to actually implementing AI in the workflow.
That is an excellent question. I think as with all technologies and assays, the actual discussions of if this will work or not, and getting instrumentation in, that took probably about a year. But once we had all the pieces in place, I would say probably about 9 months.
Yes, and that seems to kind of be maybe middle of the road average implementation timeline. We've had some go as fast as 60 days. Once the instruments arrive, they had their samples ready and they just went. So, but yes, it's a good question. And some have been significantly longer than that. So I think
and I will say too, it's like the actual validation itself didn't take that long. It's just the other pieces of working with our institution, doing the test build, training staff, all of those pieces come into play too. So that's where I kind of think of the whole process itself of instruments in and test is live or workflow is live. So
that's right. And there was an LIS integration here too. So
yes. So
and remind us your LIS, Dr. Hilt.
We have Epic Beaker.
Yeah, that was a great milestone together to integrate with Beaker.
Yes.
Okay. Was there an increase in positive samples with the AI? Were you catching a higher positivity rate?
If we did, it was negligible. Not really. I mean, and to be fair too, we have a very high negative rate of, I think we have 98% of our samples end up being negative. So it may have been a 0.5% or a little percentage increase, but nothing that was, oh my gosh, this is helping us catch more.
Yes.
But because my staff is also very good, I have to say, the baseline is very high with what we're working with. So
skilled team that knows how to read and know and P.
Yes.
Yep. Ben asked, how has the cyclospora outbreak influenced your implementation? How easy is it to introduce other stains? So I can maybe address the second half, but thoughts on cyclospora for you at University of Minnesota, M Health Fairview?
Yeah, so I will say the cyclospora outbreak did not hit us in Minnesota the way that it did in other states. Talking with our Department of Public Health, our rates were our detection rate of cyclospora and our numbers were normal with what we see every other summer. So the outbreak did not extend to us specifically. So I can't necessarily speak to if we saw more or didn't see more because we just saw the same. So
yes, no, that makes sense. And on that second question, how easy would it be to introduce other stains? So we do have several clinical customers who have used, multiple of our algorithms to identify cyclospora. We also have a modified acid-fast algorithm that's trained on images from certain scanners that identifies Cryptosporidium, cyclospora, and Cystoisospora coming here in the next couple months. But we have had several customers who have run their modified acid-fast stains through the TechSite trichrome model because that model is advisory for cyclospora. And so those dealing with the outbreak in this surge in volume, unlike Dr. Hilt's lab, they have found great value in clearing through more of their backlog by running those modified acid-fast or modified safranin slides through the TechSite trichrome model that's advisory for trichrome only officially. So there have been some creative efforts to make sure we're getting patient results faster to the physicians with the cyclo outbreak. Linda asked, do you use concentrated material for the wet prep? She maybe saw that mounting media, that Lugel's iodine.
Yeah, we do not concentrate for our wet mounts. And I'm sure my staff who is in the other room may correct me on that, but I'm pretty sure we do not. So
yes. Paul asked, do you provide any captured images with the results? The answer is definitely yes, but what would you add around what is presented and potentially captured, Dr. Hilt?
Yeah, so I think in the sense of the way that the technology works is it presents the representative image of what it could be, and it gives a possible identification for that. So an example would be like on the trichrome, it's like, here's this image, and it could be Entamoeba histolytica. And so that's how then we kind of confirm or deny just based off of that representative image there. As for if we put those images in the actual patient results, no, we don't do that. So I think that kind of captures that. And if I'm
No, it does.
Yeah,
absolutely. And that we do have some clinical customers who do choose to select a handful of representative images from the specimen that the TechSite AI platform presented to pull those over into the LIS as a few examples on either a confirmed positive or as a negative to demonstrate there was nothing material here. So that's great. Well, let's see. Carol asked, we use PTAH for our permanent smears and a combination of iodine prep and non-iodine prep wet mounts. Would this still be a process that is applicable to this instrument?
I would think so, but I think that's more your realm of if the actual software would be able to recognize the parasites well with that PTAH prep.
Yes. So Carol, we have intentionally generalized our models within parasitology and our other disciplines, but our AI models are robustly built with tens of thousands of representative images from lots of different stain looks and preservative looks. So it would probably be in domain what you're expressing, and we can learn pretty quickly. All it would take is 10 or 20 slides. You run it through and see how the model is generalizing. Linda asked, Dr. Hilt, what stool preservative did you use?
So we use I think it's like the Parapack, the Total Fix, for our, I think that's what we use. I think that's like 10% formalin, if I'm remembering correctly. Again, I'm sure my staff is like, this is what we actually use. So that's just off the top of my memory, but I could be wrong. So
yes, Total Fix, EcoFix, several others.
Just all within that brand. Yeah, or brands, several. Yeah.
Ben asked, in the Netherlands, we screen with PCR. Would technology like this still be useful for us? Did you happen to compare this with PCR?
So for our actual implementation, we didn't compare to PCR directly. I'm sure we could go back and look, but we allow for providers to order our kind of like multiplex stool PCR as well as the ova and parasite. So we kind of leave that to the providers we don't have it as like a tandem order or use the PCR as a screen before this. We leave them as separate entities for our providers to order.
And as a clinician, what would be your thoughts on microscopy versus PCR? I mean, it's the classic trade-offs, right? But is there anything you just kind of add verbally for the viewers?
Yeah, I think it's all dependent on yes. I mean, so PCR is more sensitive. We do know that. And, I think especially as we're talking with like the cyclospora outbreak, right? We know that cyclospora has like a cadence and how it's shed in the stool. You can't necessarily have a patient come back multiple times. I mean, even in the like ova and parasite guidelines, we recommend like submitting 3 stools before you fully call it negative. And so that's where I think PCR is advantageous, that you can still be able to detect that. However, I will state that the PCR should not be used as a test of cure, because we do know with the sensitivity of it that you could maybe detect the organism even after treatment, if there is treatment, for several months later, possibly. So I think that's where it's a nice balance between the two, and why I wouldn't necessarily just fully move over to PCR to diagnose everything and like fully remove O&P exams itself.
Yeah, it appears clinically the morphology remains critical for the breadth, right? I mean, the PCR, of course, is much more targeted obviously highly sensitive, but boy, there are so many organisms that are potential that would not be covered by PCR as another data point.
Yeah.
Awoke asks, can it detect for all intestinal parasites, including Cryptosporidium? So the answer is yes. TechSite has AI models across trichrome, wet prep, or concentrate wet mount, and modified acid fast. So Cryptosporidium is covered among those. And all the intestinal parasites that are analyzed or looked for in manual microscopy today are captured across the TechSite Fusion Parasitology suite. Well, that was intentional. We sourced samples from all 6 inhabited continents over many years to make sure we had a representative AI model across these different stain types. You can imagine the task of these very rare organisms, very rare parasites that are, especially in the United States, not seen very often, but we wanted one that labs could with confidence transition to digital. Is there anything, Dr. Hilt, you would add to that question? Can it detect for all intestinal parasites?
Yeah. I mean, again, it just depends on the stains that you're using. So like for us right now with our workflow, we wouldn't be able to detect Cryptosporidium with this because we do use a modified acid fast stain for that particular. And again, that's a separate test order that we even have within our system. So like for this workflow that we have, we cannot detect Cryptosporidium in it. However, we do have other methods and maybe looking at implementing the modified acid fast into incorporating that into this workflow. But currently that's a separate manual test that we still set up.
That's right. And TechSite does have a modified acid algorithm, modified acid fast algorithm with Cryptosporidium compatibility. However, not yet trained on the images from the Permana scanner, which Health Fairview is using. So yep, coming over the next few months. That's right. Okay, maybe we'll take 2 more questions. There have been a lot coming in. I've skipped some that the TechSite team will just follow up individually with you. Thank you all for your engagement. Actually, we'll just do this last one. Dr. Hilt, will you use the system for other microbiology samples in the future? Gram stain, they list as one example.
Yes. So again, as we kind of alluded to with the last statement there, we are looking at potentially moving our modified acid fast from the parasite to have the full parasite on the platform, but we are exploring gram stain as well. Just kind of working through some of that. Again, looking at the full workflow and how it's going to impact it and if it's worth truly implementing or not. So we're in those initial phases as we speak.
That's right. And these are investments, these capital instruments, right? These scanners. And so the more modules, the more test types you can add, you just better utilize the assets. So yeah, all things under consideration right now at Health Fairview. Makes sense. So,
yeah.
Okay. Thank you to our audience for lots of good questions. We'll follow up with you privately on those we didn't get to. And Dr. Hilt, our expert guest today, thanks for your participation, your preparation. It was really fascinating to hear more about your specific implementation. As always, reach out if there's anything TechSite can do to support or if you have additional questions. And a huge shout out and thank you to Health Fairview, University of Minnesota, Dr. Evann Hilt and team. We'll catch you on the next episode of the Pioneers in Digital Pathology series. Thank you.